Hello. Today we'll discuss about an article with the title Efficacy and Safety of Nipocalimab in Patients with a Moderate to Severe Sjögren's Disease, a randomized phase 2 placebo-controlled double-blind trial. So this is an article which is published in the journal of Lancet with an impact factor of 88.5, and this was published in the year 2025. So already we have discussed about the novel therapies for Sjögren's disease, and in that the Nipocalimab is a drug which is studied in this article, and this has entered into the phase 2 trial of the randomized control trial. Here it is a placebo controlled and it is a double blind trial. So Sjögren's disease pathophysiology is characterized by dysregulated innate and humoral immunity and includes aberrant B lymphocyte activity, abnormally elevated IgG and production of IgG autoantibodies, but clearly the anti-Rho, the anti-Rho60 which is the SSA, and anti-La which is the SSD autoantibodies. So these are the serum markers of Sjögren's disease. So novelties of this article is, this is a phase 2 which is a multi-center randomized placebo-controlled double-blind study, which is the first randomized controlled trial for a neonatal Fc receptor blocker. So the drug which we are talking about is a neonatal Fc receptor blocker in patients with Sjögren's disease. Although most other drugs have targeted the B cell depletion or suppression, Nipocalimab targets the neonatal Fc receptor to specifically reduce the abnormally high levels of circulating IgG antibodies and autoantibodies present in most patients with Sjögren's disease. So that is the novelty of this study, and this study aimed to evaluate Nipocalimab, a neonatal Fc receptor blocker that reduces circulated IgG including autoantibodies in SGPT patients. So here they included 163 participants between September 21 and 23. About 53 participants for Nipocalimab of 5 mg per kg, 54 to 15 mg per kg, and 56 to placebo. And 151 participants were female and 12% were male. We know SJD is more predominant in females, so female participants were more in this trial. And this phase 2 double-blind multi-center trial enrolled individuals with moderate to severe active Sjögren's disease. How did they decide whether it is a moderate or severe? Using this ESS-DAI score, this which I already explained, and also the seropositive for anti-Rho IgG antibodies. So this was the criteria for selecting the participants in this study. The participants were recruited from 69 centers across France, Germany, Italy, Japan, the Netherlands, Poland, Portugal, Spain, Taiwan, and the UC. So it was a multi-center study. And the central randomization assigned participants to one of the 3 treatment groups using interactive drug response system. So it was a central randomization which was done, and the participants were allocated in one of the 3 groups. And the randomized, that is 1:1:1 participants, received intravenous Nipocalimab, which is 5 mg per kg or 15 mg per kg, or a placebo every 2 weeks for 22 weeks. So this study was done for 22 weeks, where the participant received either the medication or the placebo every 2 weeks. And the oral intake of liquids or secretagogues, which is it might be a natural or pharmaceutical one, and the use of ophthalmic treatments were restricted on the study visit days before evaluations. So this was one criteria which they have instructed the participants. And the primary endpoint was change from baseline in the ESS-DAI score at week 24. So any randomized to the clinical trial will have a primary endpoint, so that they can stop that particular assessment and collection of data of the participants. And the secondary endpoints measured the systemic and local disease activity and the patient reported symptoms over time at week 24. So the primary and the secondary endpoints were clearly set in this study. And the results showed that Nipocalimab for 50 mg per kg group had a significant reduction in the ESS-DAI score at week 24 versus the placebo group. Nipocalimab 5 mg per kg group had a non-significant reduction versus the placebo. The statistical analysis, the sample size determined by power analysis providing 88.3% power. So usually the power they take more than 80% to detect a 4-point improvement in the primary endpoint, with 50 participants were grouped at 2-sided alpha. So they have the sample size was 50, but they have taken a little more to compensate the dropout rates. And primary comparisons used a pre-specified significance level of 0.10 appropriate for phase 2 exploratory dose finding trial with no multiple multiplicity adjustment. So in the phase 2 trial, usually they will find the dose which is the dose efficacy of that drug, and that drug needed a significance level of 0.10, and the confidence interval estimates were emphasized over the p-values. The continuous outcomes were analyzed using a longitudinal mixed effects repeated measures model, which is MMRM, adjusting for baseline scores, treatment, visit, region and baseline medication use. A hypothetical strategy was used to intercurrent events. Post-intercurrent event data were excluded without imputation, and the MMRM used all available pre-event data to estimate the treatment effects. Binary outcomes treated intercurrent events as failures and were compared using a two-sided coherent Mantel-Hansel X-squared test. All analyses were conducted in SAS. SAS is a statistical analysis system which is widely used, that is an industry standard software for advanced statistic data management and clinical trial analysis. So in any clinical trials, they use this SAS, this statistical analysis system for all the statistical analysis, and here they have used the Cochrane-Mantel-Hansel X-squared test for the analysis. So what is that Cochrane-Mantel-Hansel CMH square analysis? It is a statistical method used to compare binary outcomes. Example, a responder versus non-responder between two or more groups, while controlling for one or more stratification factors such as the study site, region or baseline severity. So here there are many factors, stratification factors, and there are outcome binary outcomes. So this test is mainly used for that particular scenario. And it tests whether the association between the treatment and outcome is consistent across the state. And in clinical trials, it is commonly used for treatment response analysis, especially when the study design includes stratified randomization. And it provides an adjusted square statistic and p-value that account for stratification, reducing the confounding and improving accuracy. So these were the results. And finally, they concluded that Fc receptor blockade by Nipocalimab of the dosage 15 mg per kg significantly improved the clinical disease activity versus the placebo, and it was well tolerated in patients with moderate to severe active Sjögren's disease. So reductions in the IgG antibodies during Nipocalimab treatment support their contribution to Sjögren's disease pathogenesis. So they have also tested the IgG antibody levels. The clinical disease activity was also compared, and they have given the conclusion that the Fc receptor blockade of the dosage 15 mg per kg improved the clinical outcome. So the limitations of this study was it is limited generalizability because the study population may not reflect the full clinical spectrum of Sjögren syndrome, including patients with the most severe organ involvement or diverse backgrounds. And the phase 2 sample size constraints, although powered for the primary endpoint, the study was not designed to robustly detect differences in secondary outcomes, rare adverse events and long-term effects. So any clinical trial, we have to see the rare adverse events which are happening and the long-term effects. Here they have done only for the 24 weeks period time. And as I said, it is a short follow-up, that is 24 week duration. And no multiplicity adjustment, that is the secondary and exploratory findings carry a higher risk of type 1 error and should be interpreted cautiously. Hypothetical intercurrent event strategy, that the exclusion of post-intercurrent event data estimates treatment effects under idealized conditions which may differ from real world scenarios. Here they use the idealized condition rather than using a real world scenario. And it was a model based assumption. The MMRM approach assumes missing at random and correct model specifications. Violations could introduce bias. So bias can be a limitation in this type of model based assumptions. So the future scope is phase 3 confirmatory trial with larger numbers, longer follow-up and perhaps more diverse patient population is a logical next step, and investigation of long-term safety, studies in real-world settings, and subgroup analysis of or biomarker-driven approaches to identify which patients benefit most, or to refine the dose or regimen optimization, health, economic, and quality of life analysis given the chronic nature of Sjögren's and need for treatments, and mechanistic studies for further understand how Nipocalimab acts in the Sjögren's syndrome, durability of immunologic changes, potential for combination therapies, and longer term safety in the real practice scenarios. So these are the future directions. So this trial appears to follow the core components of the consort checklist with the transparent reporting of design, methods, outcomes and analysis, participant flow, baseline data, the results, adverse events, limitations and funding conflicts. The authors provide a balanced discussion of limitations and future directions and clearly state the exploratory nature of the trial. So interpretation is appropriately cautious. So from a methodological perspective, the statistical methods are contemporary and appropriately described in this step.